Good afternoon. Welcome to the press briefing. I'll introduce the speakers to you. Dr. Chong Shuk Kwan from the Center for Health Protection and Dr. Lau Ka-hin from the Hospital Authority. Hospital Authority Chief Manager. Dr. Chuang will update you on the latest position. Thank you. Yesterday, we confirmed the 115th case. Today, there's one more, which is 116th. Let me briefly talk about the case 115. A 59-year-old female residing at La Grove, Sabat Hang Road, Yuen Long. She has not displayed any symptoms. She joined the Indian tour between the 31st of January and 24th of February. On the 7th of March, she was admitted to a quarantine center. On the 8th of March, a deep throat saliva specimen was taken from her, and it was tested positive. She was asymptomatic, so we would regard the 8th of March as the onset of symptoms in order to trace her close contacts. On the 6th as well as the 7th of March, she stayed at home on the 6th, so her household members would be regarded as close contacts, and then they would have to be quarantined. She's got a dog, and the dog will be taken to the FCD for quarantine purpose. On the 7th of March, again, she stayed at home, but then she was referred to our quarantine center. On the 8th of March, she gave a deep throat saliva specimen, which was tested positive, and so she was referred or sent to a hospital for treatment. For the new case today, case 116, the driver of case 106, aged 44, male, on the 4th of March, he collected his employer, that is case 106, and drove his employer home. On the 6th of March, on the 5th of March, she drove case 106 to see a doctor to Canossa Hospital and Regency Hospital, respectively. On the 6th of March, he was referred to the quarantine center by us. On the 7th of March, he started to have coughing. 8th of March, he started to have a fever. He was sent to Regency Hospital. Today, the report confirms that he has been tested positive. On the 5th of March, case 106, well, in fact, he resided with case 106, but then on the 5th of March, case 106 was admitted to hospital. So he returned to his own place at number 341 Desu Road West. He spent a night there, and then he was sent to quarantine center. So, mainly speaking, he doesn't have lots of close contacts because he lives on his own. Thank you. Next, Dr. Lau, please. Thank you. As of 12 noon today, for the past 24 hours, the hospital authority reported a total of 44 suspected cases. Together with those already staying at hospitals, we have 109 patients being treated in isolation at our hospitals. For the past 24 hours, one more patient passed away. She was case 99. She passed away at Caritas Medical Center. If I may elaborate on her conditions for your reference. She was a 76-year-old lady, retired, residing together with her husband. She had a history of high blood pressure as well as diabetes. On the 28th of February, she was sent by ambulance to the A&E department of the Caritas Medical Center. At that time, it was found that she had a low level of blood sugar. She was admitted to the medical ward. She was found to suffer from fever, difficulty in breathing, as well as coughing. So sperm was collected from her to test for the coronavirus. She was tested positive, and then it was verified by the Department of Health. Again, the test result was positive, and then she was admitted to an isolation ward. Since the 1st of March, she was given 3 types of medicine: interferon, protease inhibitor, as well as ribavirin. And then starting from the 3rd of March, in her blood, the oxygen level dropped. Despite our help, the level continued to fall, and she was in the ICU, and she was given the ventilator. At the ICU, we continued to give her the antiviral medicine, but then yesterday, her conditions worsened. At 5:13 p.m. yesterday, unfortunately, the patient passed away. So case 99 passed away. So far, 3 patients passed away. Today, or rather yesterday, 1 more confirmed patient recovered and was discharged, namely case 69. A 48-year-old male. He was admitted to hospital on the 20th of February. Again, he was given antiviral drug, and her conditions improved quickly, and then there were improvements in his lung images. He was tested twice for the virus, and both were negative, and then the DFH and us decided to discharge her. So far, 59 patients have recovered and have been discharged, and then 1 probable case was also discharged on the 6th of March. At this moment, 53 patients are being treated at 9 different hospitals, 1 in critical condition, namely case 89 at the Eastern Hospital, and then 2 other patients are in a serious condition. For the rest, there is 15 of them. Their conditions are stable. As of noon today, we have 954 negative pressure beds, a utilization rate of 35%. For the number of negative pressure wards, there are 507 of them. The utilization rate is around about 55%. So much from me. Thank you. Now the floor is open to you for your questions. We'll pass the mic to you. Please identify yourself and your media organization. At most 3 questions from each reporter. The reporter in the first row on this side.
Hi, from SCMP. So I have a number of questions. First, I want to ask more about the new case confirmed today. Can you tell us a little bit more details about the case? For example, you've talked about how the case is a driver, and he does not have many close contacts to be traced because he lives alone. But how many, are there any other close contacts of the 106 case that needs to be traced and are already put into quarantine centers or will be put into quarantine centers in due course? Also, how would you assess the risk, infection risk of drivers, such as a 116th case? Because we know there are many drivers in Hong Kong, and some would be in a similar category and situation as 116th case, who would have perhaps picked up confirmed patients, and there are also cab drivers and other lorry drivers, etc. So do you have any advice to them? And would you say they have a high infection risk because they will be contacting a lot of passengers every day? And would you advise people not to perhaps take a cab because it would also be an environment where you can get the virus? Because and also, can you perhaps tell us a little bit more about your idea of the route of transmission? Because how long has 116th case been in a same environment and perhaps in a close contact with 106th case? Because if he has only, of course he has lived in the same place with 106th case, but are they perhaps living in very separate rooms and like even within that car environment, maybe it was, how long was that duration for, and how could he has possibly contacted the virus? So that's my first question. My second question concerns the enhanced laboratory surveillance scheme that is being rolled out to private clinics and private hospitals today. Can you tell us a little bit more about how many private practitioners, clinics, and hospitals have signed up to the scheme? Because you haven't been able to tell us the names and the number of that. And we want to know that because there have been some private practitioners who have told us that perhaps private doctors will be hesitant in joining the scheme because of the infection risks, because they will be required to take nasal swab from patients, etc. And also, they would also want more help from the government. For example, that they would not have enough spaces to put the samples in their clinics. Thank you.
Okay, so thank you for your question. The 116 case was put in the quarantine camp at the very beginning because we consider him as a household contact of the case, 106. Because as a household contact, you usually share rooms and space, not necessarily sleep in the same room, but they will have many household contacts during the day. And as a driver of the case, I think they will have many, besides driving, they may help him to carry the things and with other day in, day out contacts. It's more than I think their contact is more than a commercial driver. So that's why at the very beginning we consider him as a household contact, family contact, and put him in the quarantine camp. And besides this driver, the patient 106 also lived with his wife, 3 daughters, and 2 domestic helpers. So they have all been arranged into the quarantine camp. Yeah. And for the risk of drivers, I understand there's really a risk for drivers because you may remember at the very beginning we understand there are some drivers in Japan who have been confirmed to be a case because he drives some tour from the mainland. So, but in general, I think drivers should observe strict personal and environmental hygiene. Besides wearing a mask, maybe they could consider to open the window, especially for taxis if they can, and keep the car clean, and keep maybe washing personal hygiene, especially if he can disinfect the hands every now and then, especially after contacting the passengers. And for the lab surveillance, because we have because only the public hospitals in Hong Kong, as well as the CHP's laboratory, are able to do this test. There's no commercial kits available for the private sector at the present moment. But because we know that many people may not present with very severe symptoms, or they may not have an epidemiological indicator for that they are a case. So they may not be classified as a suspected case. And then this patient with mild symptoms, just like a normal flu, they may go to visit their own doctors at the present moment. So the private practitioners has no way to test them except for referring them to the public general outpatient or A&E or for admission. So in order to assist them, so we will provide a free testing to support the laboratories, because private practitioners, usually they can also get a sample from a patient normally. Sometimes if you go to a private practitioner, they can take you a throat swab to see whether you have influenza or other illness. Of course, not every private practitioner will do this, but some of them would do that, would take a sample from a patient, and they usually have a laboratory connection, so where they send the sample. So our laboratory is supporting these laboratories. So the usual way, if they take a sample from the patient, they can send to their own lab, and their laboratory can send the specimen to our laboratory. So we can provide free testing. That's how it works. So we want to normalize the testing, so to suit into their own connections. I mean their own practice. But of course, after we issued the letter last week, we understand many doctors are very concerned because this is a new thing and it's a new virus and new testing. So in the letter, we also provide an inquiry form. So our laboratory staff and colleagues are receiving many inquiries concerning this. So they are solving their inquiries because maybe we have not explained well enough for them. And so our laboratories are explaining this to both the laboratories as well as to the individual doctors so that they can know what they can do.
Next question, please. I am from Ming Pao. Good afternoon. The first question is about the enhanced laboratory surveillance scheme. It has been expanded to cover private doctors. You mentioned that the private doctors would collect samples from citizens and then they will give the samples to their own laboratory, and the laboratory will give the samples to the Departments of Health. So have the private doctors agreed that they would take sample, and the laboratory of the private doctors have agreed that they would give you the samples? And do you worry that there may be a lot of citizens who would like to take part in this testing, and then you may not be able to handle the volume? Should a person presented with mild coughing or diarrhea be given this test by private doctors? Professor Yun mentioned today that the epidemic would only be in control when more than 70% of people have antibodies. So we may be talking about several years. Should we change the strategy for containment, or should we change the criteria like other countries, that we may move into the mitigation phase when there are a certain number of cases? And what will we do by then? If we are talking about several years to deal with the disease, do we have enough capacity to deal with it? Because we are facing the shortage of equipment already. We have suspended some medical services already. So how are we going to cope with these possibility of several years? And what about the A&ED departments? Do they have enough beds to handle patients? As I have explained in English just now, the enhanced laboratory surveillance scheme covered the laboratories of the Center for Health Protection and the Departments of Health previously. We had the laboratories to conduct the tests. But for private doctors, they do not have the commercialized testing agents for rapid tests. So we want to support the laboratories in the community. Now, even if the doctors want to conduct a test, they do not have the means to do so. They can only refer the patients to general outpatient clinic or to a hospital. For some patients, the doctor may not suspect the patients to be a case, but maybe the patients has displayed flu symptoms, so maybe the doctors would like to do a test for the patients. Actually, some private doctors in the private sectors have been taking samples from patients to carry out influenza or virus testing. If the private doctors would like to carry out a test for coronavirus as well, they can send the sample to their own laboratories. If a testing for coronavirus is not available at that laboratory, they can send the samples to the laboratories of the Departments of Health for a test. We will not charge the laboratories for this kind of service. But of course, there may be fees charged by the doctor or the laboratories. Of course, these are commercial decisions. There are only a few large-scale private hospitals which has the capacity to carry out these tests. So that's why we want to expand our service to cover them. It depends on whether the private doctors has a practice of taking samples. If this is not his practice, he may need to find his own laboratories. If he has some laboratories or he has been providing tests to his patients, he can give the vials or bottles to the patients and then collect the vials themselves and send them to test. We have received many calls from private clinics and laboratories, and our colleagues are proactively liaising with the laboratories and the private doctors and to answer their inquiries and explain the procedures to them. We are looking at how to optimize the procedures to relieve them of their doubts.
Now, for the novel coronavirus, we can see that around the world it is very serious. And in fact, we have seen an outbreak in many places. The World Health Organization has advised all the countries in the world to try their best to stop the infection. That should be regarded as the most important objective. We should go all out to fight the battle. By delaying the spread of the virus, then we can buy time to carry out preventive measures and to research into vaccines. Well, many people have mild symptoms, others don't have symptoms at all, but still it is a disease that can be fatal. So we are buying time so that we can wait for a vaccine or we can develop an effective medicine so as to lower the fatality rate or reduce the severity of the consequences. The WHO is currently giving such an advice. Hong Kong is doing the same. As to when we should change our policy, well, it depends on the expert advice as well as the WHO's advice as to what Hong Kong should do. And then you ask for the level of antibodies in the population. Well, in fact, whenever we encounter a new virus, then we will have that idea. Now, in the case of flu, if you haven't been vaccinated or if you haven't got the antibodies, you are more susceptible. Now, in a population, if we have got more people having the antibodies, then the spread would not be that easy. In the case of measles, we need a 90% or above level of antibodies before we can stop the spread of the disease. It's up to the experts to assess the level of antibodies needed. Thank you for your question. It is a very novel disease. For the hospital authority, right from the beginning, we've been tying in with the government's policy or strategy of containment. Well, usually we will make reference to the overseas experience, and we'll also get advice from our local experts. We also learn from our experience gathered in the SARS outbreak. What we would like to do is to make sure that the hospital authority will tie in with the overall strategy of containment. So we reduced our level of services so as to keep hospital beds to take care of the patients patients, and we also like to reduce the number of visitors to our hospitals to control the infection. So we are tying in with that strategy. Currently, we are making use of 30% of the beds for infectious disease. In other words, 60–70% of the beds are still available to treat the patients. You may wonder what we will do if the spread continues. Well, we will see. Currently, we don't know how long the infection will last. Professor Yuen has given his views. We have to gather more views from experts to see whether we need to review the service provided by the hospital authority, whether we should make changes. As to the question of PPEs, you know that there is a tight supply all over the world. Hong Kong is not in a unique position. Well, every week we have been transparent and telling you about our inventory. Currently, we have the supplies that will see us for a month. But then we are not going to stop there. Our procurement colleagues are resorting to global procurement directly so that we can get the PPEs for our staff members to stop the disease. At the same time, we are monitoring the spread in Hong Kong, and then we have also got the Command and Control Center, which carries out a coordinating role so that the patients will be spread among the hospitals. Patients will not be concentrated in just a handful of hospitals, which may paralyze those hospitals. So we'll make appropriate use of our hospital beds and provide the best service to our patients. The one over there. I'm from TMHK. My first question is about case 116. In early March, everybody was doing a surgical mask. Now, of course, you told us that the driver lived together with the employer. Did they eat together? And what about the risk of private chauffeurs and instead of professional drivers? And what about resumption of classes? What would be the appropriate time to do so? And then more and more people are going out. And what about the increase in the risk? What do you think? And then in Taiwan, it is said that they have developed a testing kit that would only need 15 minutes to complete the test. Are you going to liaise with Taiwan to see what you can do? Well, as to their exposure or contact, we'll try to find out more. Say, for example, going to work, picking up the employer from the airport, etc. Well, since they live in the same place, so there would be contact, rather than in the case of a commercial driver just picking up or setting down a passenger. As to whether they did share a meal together, we have yet to find out. As to the resumption of classes, it is an overall policy on the part of the government. Now that more people are resuming work and more people are going out, I think our advice is that you still have to pay attention to personal hygiene. You should continue to practice social distancing, and you should have staggered hours to go to work and to take your lunch. So the main point is that we should avoid gatherings. As to the testing kit, well, for the time being, for the hospital authority and the Department of Health, when we want to test a patient to see if he has been infected, we have the RNA, so it's a PCR. We collect specimens from a patient, and then we'll try to see whether the RNA of the virus can be found. It is a sensitive test, so that even at an early early stage will be able to pick out the infected patient. In other places on the mainland and in Taiwan, they may have other approaches. We've been monitoring the practices in all places. If it is going to help us, we'll try to introduce that approach into Hong Kong. But then currently our test has given us accurate results. Both the hospital authority and the Department of Health have been using this RNA test, and it is accurate in outcome. Yes, the gentleman in the fourth row. I'm from cable TV. For case 116, that's the latest case. Can you give us more details about the driver? Is he also of Indian ethnicity? Does he have his own family here? And then, before the onset of symptoms, did he have a travel history? And then, about the enhanced laboratory surveillance program, Dr. Chuang said that they have been liaising with the laboratories as well as the private clinics. I want to know how many of them have indicated their interest to take part. And then, how much time will be needed to get the result? If the patient is confirmed, I want to know whether the private doctor or the private laboratory have got the responsibility to trace the patient. And then if the patient doesn't want to present himself for a test, but then if the doctor thinks that he should undergo a test, what can be done? Have you decided on what to do about such a case? And then for the case in which you said that the patient passed away, you said that her conditions worsened. Was there any organ failure? Could you elaborate on that? And what about the other two fatal cases? Have you identified any common points so that we know that what will make a patient more susceptible? Well, for case 116, no, he did not have a travel history. He's on his own. He doesn't have a family here. But of course, we need to ask more questions to find out whether there are other contacts that are not yet known to us. Yes, he is of Indian ethnicity. As to the number of private clinics taking part in the enhanced surveillance program, we haven't got a figure. It depends on their response. Currently, what happens is that after they have collected the samples, the doctors have collected the samples, the laboratories will send the samples to our laboratories and will carry out the test as soon as possible. Probably within the same day or on the following day, we'll be able to get the results. Of course, I'm talking about weekdays from Monday to Friday. Once the results are known, we will be notified in the first place. Now, if the private doctor has left behind a telephone number, as you know that sometimes it's late in the evening that we get the result. If we have the telephone number of the doctor, we will approach the doctor. We'll also approach the patient and admit the patient, just like in the case of the general outpatient clinic. So for patient's telephone number, it will be a very important piece of information. Even if we can't locate the doctor, we will locate the patient. And of course, we'll also ask the doctor if he has already put in place all the necessary infection control measures when he sees the patient. And so we'll see if it is a probable, a suspected case. If it is a suspected case meeting our reporting criteria, like having traveled or having some sort of exposure, then the doctor should notify us, and then the patient should be tested within a hospital setting. For private clinics, usually doctors see patients that are not a suspected case. Usually it's a patient with some with a cold or coughing, and there's some suspicion. So even if the patient refuses, there isn't anything we can do, because after all, it is not a suspected case.
The patients on the 3rd of March in early morning her lungs were deteriorating. The oxygen level was dropping. We have given her oxygen assistance, but the oxygen level did not improve, so she was sent to ICU. Her condition did not improve, and she was on ventilation assistance. Yesterday, her heartbeat rate kept dropping, and then at 5:13 in the afternoon, her heart stopped beating. So we declared death. About the common traits of the three deceased patients, the first patient was a 39-year-old male. The second one was a 70-year-old male. The third one was a 76-year-old female. They were all of advanced age. Looking at their history, they all have diabetes. But it doesn't mean that the diabetes was a cause of death. But we understand that diabetes and other chronic disease would pose obstacles to recovery. We only have 3 deceased patients, but actually back in February, there was a report compiled by the WHO and Chinese experts about the situation of novel coronavirus in China. The report mentioned that 2,114 patients passed away, and some analysis have been done. The first point is not very surprising. Fatality rate is higher in groups of more advanced age. And secondly, males have a higher fatality than female, and also for those with chronic disease. They include cardiovascular diseases, hypertension, and chronic respiratory disease, and also cancer. With these chronic disease, for those who have these chronic diseases, the fatality rate would increase. Now, we only have 3 deceased patients, but from the analysis carried on the 2,000 patients in the report, it seems to match our patients' profile. Most of them were males, and they were of advanced age, and they had underlying chronic diseases. Next question, please. I'm from TVB. An airline company has laid down a rule that before boarding the plane, passengers need to show a health certificate to show that they are not infected with novel coronavirus before boarding the plane. But is it so easy for passengers to get such certificates? And what if they have urgent business to go abroad? And about the enhanced laboratory surveillance program, some doctors mentioned that the procedures are too complicated. And how will you address these comments? And what will you do to improve the procedures? And are you concerned that people will use this scheme improperly? Professor Yun mentioned that there might be as many as 800 cryptic patients spreading the disease. So are we having a large-scale community outbreak? Well, I haven't heard anything about the health certificates for boarding a plane. In the private sectors, the testing service is not available yet. Maybe the testing service is available for some private hospitals. Maybe they can issue these certificates, but that's the first time I heard about it. About enhanced laboratory surveillance program, we wanted to make the procedures as simple as possible to tie in with the private doctors' usual practice. If they have inquiries, they can call our hotlines. Actually, it is in line with the private doctors' usual practice. If they have been taking samples, they can send the samples to their own laboratories for testing. But maybe it is because of the this novel coronavirus that caused concern. Actually, this is not as complicated as some may think. We are just providing support for the testing procedures to provide free testing for the patients. We are not trying to add another layer of procedures to make it more complicated. But maybe we need to have better communications between us, and the colleagues at our laboratories are currently in liaison with the private doctors, trying to optimize the procedures. The third question is whether there are cryptic patients spreading the virus in the community. We consider it possible because we are, after all, having a surveillance system. And what a surveillance system can do is to keep on monitoring the number of patients. But there are asymptomatic patients. Maybe they have caught the virus inadvertently, and they will be able to spread the virus in their community. What we can do is to maintain personal hygiene and to maintain a social distance with others and wash our hands as much as possible. That's what we can do. On the government's level, we can contain the close contacts of confirmed patients and to try to contain the spread of the disease. Next question, please. I'm from Oriental Daily. I have two questions. About the 116th patient, can you confirm that he is a locally infected case but not an important case? And what has he done when he was picking up his boss at the airport? And we have seen that the newly confirmed case were imported from India. Is it going to be the trend in the future? Actually, there are many immigration border control being in place. But what about the entry and exits of India and Japan?
Case 116 is likely to have been infected by case 106. So it's a case of infection by close contact, so it's local. I understand that even if you want to meet your friends or relatives at the airport, you can't go inside. So you can't go inside the terminal. I think it's not a matter that the airport is a high-risk area. It is all because he has come into contact with an infected case, and so he gets infected. Now, of course, after a number of clusters locally and earlier on in the beginning, we have got imported cases. Now, currently, we are seeing more imported cases. Understand that the government will take an overall view and will look at the global picture to see what measures have to be adopted and how stringent in relation to the surveillance. Once a decision is taken, it will be announced as soon as possible. The reporter over there. I'm Chen from Hong Kong 01. A number of questions. First of all, contact tracing of confirmed cases. Now, for the Indian tour group, 21 members. How many of them are in Hong Kong? How many not? How many of them have been traced and sent to quarantine centers? How many of them have presented symptoms and have to be hospitalized? And then for the case announced yesterday, 41-year-old male, he took flight CX250 from Britain. I want to know whether he's related to the other case. And then for the enhanced laboratory surveillance program, some private doctors told us that they would prefer the patients handing the files containing the specimens to the laboratories than asking the clinics to act like an agent to collect the files from the patients and hand them over to the laboratories. Is it possible to do so? And then for Professor Yun, he said that unless and until 70% of the population have got the antibodies before we can see a stop. But then 30% of the negative pressure beds are being induced. But you have achieved this at the cost of reducing a lot of non-emergency operations and procedures. I wonder if we have the capacity to cope with such a high level of population infected. Well, for the Indian tour group, we have traced all the contacts, 12 in Hong Kong, 8 overseas. We have notified the relevant authorities. Understand that the Canadian authority has contacted the group members. For the 12 in Hong Kong, 5 have been confirmed. For the rest of them, they are either in quarantine centers or in hospitals. So far, we haven't got any preliminary positive cases or confirmed cases in addition to the earlier ones. Countries, for the 8, are they all in Canada? 7 in Canada, 1 in the UK. Hospitals, I understand that 1 has been hospitalized, but then I think the person involved has been tested negative. For the others, we are also getting specimens for the test. As to the enhanced surveillance program, well, it's a matter of arrangements between the private doctor and the private laboratories. I think they can have their own arrangements. Sometimes they can arrange for the patients to send the vials to the laboratories directly, or if they have been collecting the vials from the patients directly, they can see if they want to change the arrangement. It's their own arrangements, but if they need our assistance, we can try to see if we can help. Well, as to the 2 cases having a serious condition, well, they are case 26, a male 42 years old at Prince of Wales Hospital. And then the second one is case 72, a 62-year-old male staying at United Christian Hospital. Just now, you also asked about our contingency plan. As I have said, this is a novel coronavirus. As to the trends, they are still being monitored by us. I just mentioned a report, and then last month, WHO and China jointly issued a report. We have got 2 professors on that expert group, Professor Yun and Professor Gabriel Lam. A lot of the patients are mild cases. We'll continue to study the reports, and we'll also look at our daily positions. Every day, the hospital authority calls meetings. We'll look at the spread, we'll look at the number of beds used, and how we can redistribute the resources. What I can say is that for the beds available, 30% of them have been used. I'm talking about the negative pressure beds. As to the future, last week we already said that we would be converting some ordinary beds into negative pressure beds with filters as well as the exhaust fans or ventilation fans. In this way, we can increase the number of beds needed. In other words, on a daily basis, we are trying to find ways to cope with the infection. We hope that we can improve our services so as to give a better treatment to our patients. Yes, the one in the second last row. I'm from Hong Kong Economic Journal. Back to the question about the Indian tour group. Cases 111 and 115, both are members from the group. For case 111, on the 5th of March, you contacted the patient and admitted to hospital. But for 115, it was only the 7th of March that the patient was admitted to hospital. But in fact, the first case in this cluster was admitted to hospital on the 4th of March. So why has it taken so long to send 115 to the hospital? Because the delay may mean that the patient might have already infected his or her household members. For the Indian tour group, we have 2 asymptomatic patients. You have only told us about their whereabouts 2 days beforehand. But they might be infectious or contagious even before the onset of symptoms. You said that probably they were infected while they were on the tour. Can you not sort of tell us more about the places they visited beforehand so as to make sure that we can carry out the necessary procedures? Well, the HA told us that as a result of the enhancement of the surveillance program at the general outpatient clinics, even patients or people without any illness have presented themselves at the clinics. Would that add to the workload of the clinics? And please tell us about the daily capacity of your laboratories. How many cases can you cope with by enhancing the program? Are you adding to the pressure? And what is your advice to the citizens? Under what circumstances should they ask for a test to be carried out? We are tracing the contacts. At first, we had to establish whether all the 20 group members were in Hong Kong. Well, at first, the patient was concerned about privacy, so preferred to talk to her friends first before handing over the telephone numbers to us. But we have been going after the group members. Maybe in the beginning, some of them were not available on the telephone, and later on we were able to contact them. So sometimes it's difficult to tell as to why this happened. There are people who might not answer their telephone calls frequently. As to the samples, well, our laboratories are ready to take on more tests so that we can enhance the surveillance. The hospital authority has already tested the inpatients for they are talking about hundreds of them. They also cover the outpatient clinic patients. For us, we can take up to 1,000. So I think we can cover the samples from the private doctors.
What about the 115th case? Actually, that is normal. Learning from the mainland, we have set a scope for tracing people with asymptomatic who are asymptomatic. We would use 2 days prior to the onset as a scope for tracing. We cannot extend the scope of tracing unlimited. Next question, please. I'm from Economic Times. About the Indian tour group. Was there an agency to organize the trip for them? And what was the itinerary of the trip? And several cases were presented with diarrhea. So was it possible for the virus to be transmitted through this route? About the enhanced laboratory surveillance scheme, actually not many private doctors have participated in this scheme. So what is the purpose of this scheme, and how many private doctors should participate before your goal can be achieved? Actually, it was an agency, a Canadian, which organized the trip with Hong Kongers as participants. So we have liaised with the Canadian agents to find out the details. We understand that there are 21 in the group, including the patients. We have obtained the itinerary in India at the outset, and we have sent the itinerary to the relevant authorities for following up. It includes Mumbai and some places which I cannot pronounce, and they have stayed in different hotels. The tour lasted an entire month. At the very beginning, when we obtained the itinerary, we have sent it to the Indian authorities for following up. About the participation of private doctors, we do not have a number in mind. There were 50 who, at the beginning, but many would worry about the stigmatizing effect. So every day, we only receive single-digit numbers of samples. So we understand that the private doctors may be worried or concerned. So actually, the scheme has been extended to all private doctors. If a private doctor has obtained a sample, he can send it to us. But of course, the private doctor can refuse as well. We would like to normalize this system that patients can be given testing by private doctors as well. Hello, I'm from Apple Daily. Do we have no preliminary confirmed case today? And about the 19th sick case, the male police officer in the Mill Gathering, he was discharged yesterday. Does he need to attend follow-up? And previously, some people who have been discharged need to take 1 or 2 more lung scans. Is it the same for the police officer, and is he back on work immediately? And previously, for some people who have been discharged, although they had antibodies, they still face a risk of relapse. So how do you assess the risk? And about the 85th patient, Yvonne Zhao, she was discharged, but she has a pet, the Pomeranian, who was tested with a low-level infection. Is the dog still being kept by the Agriculture, Fishery and Conservation Departments? Today, there is an Indian patient who also has a dog. Is the dog also vulnerable to be infected? The AFCD has advised the pet owners not to kiss their pets. In Yvonne Zhao's case, has she kissed the dog, or how many times have she kissed the dog? Can you give us these details? As of now, we don't have any suspected case, preliminary suspected case. So we probably won't have any confirmed case announced by the HA tonight. But since we are doing a lot of saliva sample testing from the general outpatient clinic and hospitals, if we have found any positive cases, they will directly become confirmed case. So we don't have any preliminary confirmed case now, but it doesn't mean that we won't have any confirmed case tonight. About the 69th case, or maybe I will first talk about the arrangement for discharge. For the 69th case. It was a male, 48-year-old. He was hospitalized on the 20th of February. In hospital, he was prescribed with antiviral medication, and he showed good progress. For 2 consecutive days, he returned 2 negative tests with 24 hours apart. He has been assigned follow-ups, and when he was discharged, a lung scan was taken. When he attended follow-up, of course, we would ask him about his recovery progress and how he was doing, and he was advised to keep a mask on and maintain good personal hygiene and to avoid going to crowded places or gatherings. About the dog, as far as I know, the AFCD took some samples for serum testing, and they said it would take some time. So far, we don't have any new progress, but we will follow it up with the AFCD. Concerning the possibility of transmission between human and dogs, after all, this is a new virus, and we don't have such evidence of such transmissions. But the AFCD's health advice is out of prudence. What about the police officer? Is he back on work? I don't have information about that now. As I said, after discharge, the patients would be reminded about personal hygiene. And when the police officer will be back to work, it all depends on how long his sick leave is. I'm from the Stand News. This morning, Professor Yun said the global transmission link could not be broken, so it means that the epidemic will not end in a short time. For the people to maintain such a high level of alert, does the government have the responsibility to provide citizens with basic equipment like surgical masks? And the guidelines for medical staff for using equipment. Actually, in the past month, there have been 5 amendments concerning guidelines, like the guidelines at triage stations. Dr. Zhang, you said you were following the WHO's guidelines, but there have been amendments on the 3rd and 4th of March. So, actually, whose guideline are you following? Or is it because there is a shortage of protective equipment? Dr. Lau said there will be ongoing procurement efforts and the stock can last for a month. Were you referring to N95 respirators, surgical masks, or protective gears, or protective gowns of a certain level? Because there has been a shortage in terms of protective gowns.
The professor has said that it is going to last for a while. Probably from now on, everybody has to pay attention to environmental hygiene and practice hand hygiene, wash our hands. As to the standards for the surgical masks worn by medical and healthcare workers, I didn't make a comment on that. Well, it is unknown. It was unknown before. All over the world, we did not have any knowledge about it. And in fact, it is over the past 2 months. We have been gathering more knowledge about it. A moment ago, I referred to a report, and in that report, it said that it is mainly droplet transmission and contact transmission as far as this disease is concerned. Well, in this case, in theory, a surgical mask can stop droplet transmission. On the way, we have been gathering more information, and the WHO has also been amending the guidelines. I think that was mainly about the protective gown. We followed suit. At first, it was grade 3, and then it is grade 1. Well, that protective gown is to protect our staff members so as to stop the contact transmission. Well, I think it's all about the waterproof. For grade 3, it is absolutely waterproof. For grade 1, it is not as good, but still it can be waterproof to a certain extent. I think it's all about the pressure. Like at our triage station, our nurses there, well, the chance that they will be splashed with a lot of water is low, because if you go up to a triage station, I think the nurse would only be getting the information from the patient. So we have to strike a balance. Now, we have to check whether, clinically speaking, it is the appropriate level, whether our staff members can be protected. So we have got standards, we have got evidence, and we have considered the appropriateness. And then experts have also given us the feedback, telling us that it is fine to make the change, and it can still protect our staff members. In this case, we will then amend our guidelines accordingly. Well, you talked about the 2 days, and how come that there was a change from A to B and then back to A within a short span of 2 days. I'm sorry about that. There was some misunderstanding. Well, after that meeting on that day, there was some discussion. Well, we weren't making changes to our standards. Rather, it is a matter of whether we would like to make a change in our operation. But then some colleagues might have some misunderstanding. And so the standards were amended and uploaded onto our website. The following day, when we became aware of it, we took it down. Now, if you read carefully, for our standards, at first it was surgical mask / N95. In other words, both would do at the triage station. But then, as I have said, we took into account various information, like the features of the novel virus as well as the expert advice. So we believe that surgical masks could still protect our colleagues. But at this stage, we would want to get more information. We would like to have more communication with our staff members. And therefore, we have adjusted the grading again. We would like to have a thorough discussion before we know what to do, so that we can convince the colleagues that we have listened to them. So let me say this once again. I'm sorry about that. We acted just a bit too quickly, and it was a matter of misunderstanding in the communication. I just want to say that since the outbreak of the disease, the management of the hospital authority has been collecting views and feedback from our frontline, from our management. You know that our chief executive went to different clusters to attend their forums. We have also got a 24-hour hotline so as to get questions from our colleagues and to get suggestions and comments from them. We will certainly listen to our colleagues and we'll discuss the views of the frontline officers. Because they are at the front line, they know what we should do to protect them, and then we'll make fine-tuning adjustments. What about the last question? Yes, as far as PPE is concerned, masks, face shields, goggles, gloves, and protective gowns. When we talk about an inventory level of a month or so, this is an overall figure. Probably you have noticed that for certain PPEs, there is a shortage all around the world. say, for example, N95 respirators. But then we would like to take an overall view, and then for the time being, even if we are using the stock at the current utilization rate, the inventory can still last us for a month. We'll continue to have direct global procurement. Now, you know that the number of masks has kept increasing instead of having used them for a week. Well, sometimes we are able to take delivery and then the number will go up. And we're grateful to our colleagues for being cautious in using the mask. So we can see that there's been a drop in the utilization or usage rate. Not that they haven't used it, but then they know how or when to use it. Say, for example, instead of getting different people going to a particular place, they have the same team doing the task, and then we can save some masks. So we're trying to save the ammunition to win the battle. The last question, the gentleman in grey.
So 2 Hong Kong people so far on board the cruise ship Princess Diamond Princess have died. Does the government have any information about the rest of the Hong Kong people who are still stuck in Japan right now, and what's their condition, and does the government have any support for them? And also, secondly, the EXCO member today, Lam Ching Choi, he says that he thinks that classes should resume in mid-April. Do you think this would be an appropriate time for classes to resume? And thirdly, about the enhanced lab surveillance program, do you have an estimate of how many private clinics are going to take part in the program? And as you said, some private doctors may be worried about the risks of infection. And so what support are you going to give them to convince them to take part in your program? Are you going to provide them with some protective gear to persuade them into taking part in this program? And also, would you advise people to go to private clinics instead of public hospitals to seek for treatment if they show any symptoms of the coronavirus?
For the Princess Diamond passengers in Japan who are, I understand the Immigration Department still has a team there to assist those patients, so I do not have the details on their health conditions. I think resumption of class is a government decision, so I don't have any further details on that. I also do not have estimation of the response of the private practitioners on this enhanced laboratory surveillance program. We try to extend the testing to the private practitioners because currently there's only the tests are only available in the government laboratory, the CHP laboratory as well as the hospital laboratories. So we understand, according to our the cases we recorded during the past months, many people who attend the private practitioners before they came to our notice. So they may be presented with very mild symptoms, and the doctor would not suspect she or he has the new illness at that time. That's why we want to give them the support, give the private practitioner the support in case they want to test the patient. We can provide the test through their own laboratory, the network, so to simplify the process. But of course, after issuing the letter last week, we understand many doctors have concern about how to take the specimen, where to send the specimen, and the procedures. We try to fit in their own procedure. I mean, if they had taken specimens before, normally when they see a patient, they will take some specimen, some of them, and then they have a laboratory connection. So we try to tap on that connection to support the laboratory. But currently we are answering some inquiries from the laboratories as well as the private doctors in order to streamline the process. So we try to see how we can refine the logistics so that to improve their participation in the future. Yeah.
That's it for today's press briefing. Thank you.